28th committee meeting and ask for a motion to approve the minutes of the committee meeting.
So moved.
Do I have a second?
Second.
All in favor? Aye. Any opposed? Any abstentions? Okay. With that, I'll turn it over to the illustrious Dr. Cobb so he can.
All right. Goal is 5 minutes early, so let's go. So we always start with our Metro Health True North, and every patient we touch will receive equitable, safe, high quality, patient-centered care to afford them the ultimate patient experience. And as we go through this today, we're going to be really showing and highlighting our CPI team where you'll see how every voice is certainly listened to and help us through our quality and operational efficiencies. So to start off though, we're going to start off with a great catch story. Unlike a video, we have a live story today. So Stacy and the crew is going to come up and introduce our great catch.
You can stand anywhere you'd like.
Okay. Yep. So it's my honor today to recognize Kara Sullinger. Kara Sullinger is a nurse in our emergency department. She's been a nurse for 5 years and 4 years in our emergency department. So at our last meeting, I had shared with you what a great catch is. So a great catch is a safety event that is recognized by either process, by chance, or a caregiver before it reaches a patient and causes harm. The great catch is a great opportunity for us to look at system improvements and focusing on the process before there's significant harm to the patient's opportunity for learning. So let me just tell you a little bit about the incident. There was a busy day in the emergency department. A trauma had come in. There was a lady who had been found down in her apartment. During the trauma, the patient's heart rate started to drop as well as her blood pressure. The physician called for dose push epi. The pharmacist handed up the dose push epi. It was handed up to Kara. Kara stopped. She looked and noticed that the medication was phenylphedrine, not epinephrine. So she said, got clarification, hey, what do we want here? Epinephrine? And the physician said, we want epinephrine. Kara then, after that, did the clarification and gave the medication as ordered. About this incident in particular is that it was self-reported by the pharmacist who actually handed up the medication. This pharmacist had shared with the medication safety officer that what he heard when it was like IV push, dose push epi, he thought of phenylphedrine. That's what he was familiar with, and for him. So for that, what Stephanie has done, she actually did education with all the pharmacists as it relates to this, because the pharmacists actually come to the codes. They are a part of the codes. Some may not be as experienced with as others, as well as in talking with Stephanie, they're looking at how can they do another way, since this was human error, to truly identify to prevent this from occurring again. So Kara, tell me, what made you feel so empowered to stop the lie?
I think in the emergency department, it's a very judgment-free zone. So just like the same way the pharmacist was able to self-report, I think people aren't nervous to make a mistake and speak out if they do. I think and it was a good team working. I think we're all comfortable enough.
Sure. And now I have Laura Schmidt, our Director of Nursing for Emergency Medicine, and I have Travis McDonald, the nurse manager. Tell me, as leaders, what behaviors do you display to foster a speak up culture in the emergency department?
I can take some of this. So we've done a lot of work with culture down in the emergency department in the last probably 4.5 years or so since I've kind of taken over. One of the things that we really foster is this type of environment where nobody is above anybody else except the patient. So everybody's on a first name basis, whether you're a pharmacy, whether you're nursing, paramedics, PCNA, EMRs, providers, residents. Everybody is willing to go and talk to everybody. No one gets offended if someone questions their judgment or questions the order. Because again, we're all here for the safety of the patient and the care of the patient. So that's really kind of a process that we put in place and the culture that we're trying to build down there and continue to build off of. This is a great example of that. It's showing in other ways, our patient experience scores, everything filters down from your culture. So as long as you have a good culture, everything else kind of rises to the occasion. Travis, do you want to add anything that you've done specifically in your ED?
I think it's just using, we use these incidences or the origamis as learning points instead of being disciplinary, which is a huge thing.
Yeah, I don't think anybody does these things on purpose, right? 99% of the origamis that come across is not because somebody is actively trying to do something to harm a patient. You know, a lot of it comes down to straight process driven type stuff. So finding these things out, getting these good catches is the same thing as if you would have had a safety event come through, because you still need to look at the process. She just caught it before somebody else may have not caught it through the process.
Any questions?
I'm not at all familiar directly, happily, with the culture of the trauma center. But I suspect that the speed and complexity upon which you have to work creates greater chance of making a mistake. Is that a fair statement?
That is a fair statement. So when you're looking at the various contributing factors and you're talking through an event, you talk about those type of things, what's occurring in the environment, what's occurring at that particular time. You're looking at staffing, you're looking at all of those things that, as I often say, is on the blunt end versus the sharp end, and the sharp end being the caregiver and the patient. And how do those things, when you're looking at the contributing factors, line up to where we take that opportunity to make the improvement?
So I'm gonna do my end. So 45 years ago, when I first became a nurse, that culture didn't exist. And if that error had occurred, the individual would have either been disciplined to include potential termination, as opposed to trying to identify how to prevent harm from, being transmitted to the patient. So the fact that over 45 years, we've gone from culture where the fingers would have been pointed, no, I didn't do it, I heard it the correct way, because you didn't want to be suspended, or you didn't self-report, because if you self-reported, you would have been disciplined. So that's, great kudos to where the culture's gotten. And, the question is, how can we help you sustain it? Anything the board can do to help you do that, we're here for you. So we thank you for being here today. So. Great story.
So just a great show of the continuous learning that Dr. Alexander and I are really pushing for. And that culture of willing to report. And just so the board understands is that events like these get just as much scrutiny as an event that reached a patient. So we would have done the same thing in the same review had this reached the patient, because we want to stop it before it reaches the patient like was done here. So how can we improve upon that? So just a great story. We're going to move then to our continuous improvement at Metro Health. As part of quality, what oftentimes gets overlooked is performance improvement or operational improvement. So we have Mary Kate Wainwright, who's a principal in our CPI team. She's just going to walk the board through what the CPI team is and what we do, and talk a little bit about what's going on in our perioperative space. Mary Kate?
Thank you, Dr. Yellow. Yes, my name is Mary Kate Wainwright. I am here representing our continuous performance improvement team, or CPI team at Metro. I am just one of a small but mighty team. So there's 5 of us all together, 5 principals, 6 of us, and 1 analyst as well. We are clinical and non-clinical staff, and we work across the system in clinical and non-clinical engagements. We utilize Lean Six Sigma methodology. We're all green belt trained and utilize several tools to help us reach our goal of continuous improvement. You'll see a lot of the ways that we accomplish this, but as we go through today's talk, I'm going to explain a little bit more about some of the key tools that we use and how we use them. Next slide, please. So this is our standard work, and standard work is exactly what you think it is. It's a documented, standardized, efficient way to accomplish a task or a role. And this is what we use. So this is our continuous performance improvement standard work, starting with getting frontline staff input, understanding what the true problem is, getting to the root cause and choosing our KPIs, implementing countermeasures, and getting all the way down to where we're tracking it and ensuring success of our programs. So I'll walk through on the next slide. We can walk through how we're utilizing our standard work in one of our large engagements. So right now we're working with our perioperative team, and perioperative services is really large encompassing. It encompasses the operating room, the OR, our endoscopy area, our IR, which is our interventional radiology area, and our heart and vascular area. So that's a lot to focus on. So when we initially engaged with them, our main goal is to improve patient experience, staff experience, safety, and quality, and really putting the patient and the staff at the center of everything that we're doing. So we decided, let's focus on one of those areas. So we decided to focus in the OR first. And so if you look at that first signpost there, we get our frontline perspectives first. We spent about a month doing observations and looking at all of the roles across the OR, interviewing our staff, going back and validating our observations to make sure we had things correct. All of that sort of culminated in what we call our rapid process improvement meetings. So our rapid process improvement events, or RPI events, that I'll probably mention a few times, really we pull in our frontline staff. We did not have leadership in the room. We had frontline staff in the room, and we got their perspectives on how do we work towards our goals. Our goals for this project are to increase our first case on time starts. So that is what it is. It's first case. So when we have operations that start at 7:30, making sure that they actually start at that time so that the rest of our day moves smoothly. And then also our turnaround times. So that's from the time a patient leaves the OR to the time the next patient gets to the OR. So cleaning, making sure you have the right setup, the right equipment, things like that. So we wanted all of our efforts to really focus there. And so we went to our frontline staff and said, how can we improve this? What's going on? You're doing the work. You tell us what you need. And so we had that meeting, and then we collated and aggregated all of that data. So we had a psychologically safe environment so we could take all of that to our leadership, looking at those KPIs of the first case on time start and the turnover, and say, how do we want to take that feedback and how do we want to move forward? So the second signpost here gives you some of the ways that we are moving forward and working towards our countermeasures. A couple of them to highlight, our Central Sterile Processing Department, CSPD, their workflows. We were finding maybe some trays didn't have all of the instruments available. Maybe some of them had sterility issues. So we're really going to start to work with how we eliminate and minimize those. Case order sets is another one to look at. Our whole process starts from the time a patient decides that they're going to have surgery to the time that they go to the recovery unit. So that timing of deciding to have surgery, that's when the order is put in our Epic system for our patients. We need to make sure that that has the correct orders involved with it, the correct timing, so we're booking the correct OR time. It has all the correct equipment, so we're not missing anything or having something that we might need differently. So really focusing on starting from the beginning to make sure that that process is set across. And that's just a couple of the things that we're working on. Another big piece that we heard was that people wanted to understand their roles and they wanted to understand the roles of others that they work with. So really making sure they knew everyone doing the same role was doing the same thing the same way every time. That's standard work. So we've been working with nursing, surgeon, anesthesia, schedulers, and our pre-admission testing department, PAT. We've been working with them to create standard work, and that's just the start of it. We're going to be continuing to create standard work across the perioperative platform in the OR, and then moving beyond that as well. We worked with our frontline staff again. We pulled them back and made sure we were getting the whole role correct. We also worked with leadership to help make sure we were putting together what ideally needed to happen for those roles, and have been developing that. That's in progress, but we just went live with our nursing roles and our department scheduler roles this past week, which is great. Along that same side, as we said, it's the ideal state. So what should everyone be doing? Not necessarily what is everyone doing, but what should they be doing and what order should they be doing it in? And that's how we get those ideal state perioperative workflows on that fourth signpost there. So then we have both standard work and we have the ideal state workflows, all going towards those KPIs of turnover time and our first case on time starts. The one source of truth that we really wanted to look at is we worked with our steering committee to say, we get a lot of data in Epic. It's displayed in dashboards. It's displayed in our Tableau dashboards. And how do we know how do we measure success? How will we know what our success will really be for this? So we came together and we said, this is the dashboard we're going to use. These are the parameters we're going to use around it. And this is how we're going to measure our success. So we meet monthly, and every month we track to that. Even as we haven't, as we've just started doing these implementations, we've been able to say, we have history and we have moving forward how we're going to measure success. So we did that with our steering committee as well. And sort of all of these 1 through 4 culminate in our accountability. So culminate in making these changes and sustaining these changes. So we work with leadership. We've created leadership support tools. We involved leadership in creating the standard work and creating those ideal state maps. And so they're really the ones that are going through now and understanding what's happening, discussing it with their staff, making sure, going what we call go to Gemba, going to see the work to make sure it's being done the way that we've all agreed that it should be, and then empowering them to make sure that their staff sustain this. So what was nice is we often present in our steering committees. And this past month, we were able to kind of flip it where our leaders were presenting the work that we worked with them on, and then they're owning it moving forward. So we're in the middle sort of this journey, but it's been, it's a really good way to sort of show how CPI works and how we really start with the staff and the problem and kind of move forward to solutions. Next slide, please. So we wanted to show you 3 of our bigger projects that really hit our quality, safety, and experience bucket within the IPCX umbrella. So for patient quality, we had an ED sepsis bundle. That is a CMS core measure that we needed to be making sure patients who present with sepsis are managed soon and are managed quickly so that we can make sure that we treat them in the most appropriate way possible. Pre-intervention, when we just started to look at this across the system, there was a 32% adherence to utilizing that sepsis shock bundle. And so we met as a team and decided, how are we going to move forward? There was an RPI event associated with this, bringing the staff forward. And it was decided that most patients do present with sepsis to the ED. So to focus our efforts on the ED to try to see how we can capture most of those patients. So they created an ED sepsis team, like a sepsis code team that would come in. They also standardized communication across the board, implemented those changes, and post-intervention at 3 months, we had an 80% acceptance rate. So it's a 48% improvement, which is great. Another thing to note is nationally, everyone's at about a 56 to 57% adherence rate to this. We were below that and we went way above that with the intervention. So it was a really positive intervention that we did. For patient safety, this is an OR project. So this is a sort of a 2-step project. We have pre-procedure icon readiness. So what we were noticing is patients who, from the time they enter the facility on the day of surgery to the time that they go to the OR, we were having some issues with, maybe a consent was signed, but it wasn't dated and they're going back to the OR, and then we have to do rework to make sure that happens. And we're delaying cases doing that and making sure that our patients have the regulatory items that they need and they're fully ready for surgery before we wheel them back to the OR. So we don't have to do that rework and we can make sure they're as safe as possible. So we, on the OR status boards, added 6 icons to start that explain, that had things like, you need your H&P, you need your site mark, history and physical, you need your site marked for surgery, you need your consent. And as those items are checked off and done, the icon falls off the status board. So as a nurse or provider working in that space, you can see clearly what a patient still needs in order to be ready to go back to surgery. And then in the end, currently it culminates in a green bed with a check mark that means safe, ready to go, wheel them back to the OR. So everyone's still doing the same workflow that they were doing, but it's really that double check. And it put a lot of support into the pre-op nurses' hands to make sure that they're the ones who really own this process, to make sure that these things are ready and their patients are truly ready to wheel back to the OR. To do this, we did one rapid process improvement event to start to figure out how are we going to make sure that our patients are getting back safely. And then we did a second one after we started our recent engagement with Peri-op, where they said, this process works great, we could just use a few tweaks. And so that's where the green bed came in, and we had another icon added because they were utilizing the process and they liked it and it worked as is, but it wasn't perfect yet. And that's what continuous improvement is. So we said, okay, how can we make it better? So we added these 2 icons recently, went live with that, and it's been going well. Prior to the initial implementation of these icons, we had 23 events where patients were, like we said, coming back with maybe signing a consent but not dating it, or having small issues that needed to be, reworked before they could start their case. To 3 months post-intervention, we had 1 event. So it was a 96% improvement. It was excellent improvement, really showing that this process worked. And then again, we went back and said, but we can make it better. And we're working on doing that. We did that now. So really stellar results for that.
Just to give an example of why that consent is so important, we had patients pre-intervention going to the OR without a consent, realizing that after the patient's asleep, you don't have consent, requiring you to either go out to the waiting room and talk to a family member or abort the surgery, wake them up and obtain appropriate consent. So those types of things are what we were seeing here in the past that this has helped to eliminate.
Really great. And in the patient experience bundle, I'll speak about this one quickly, but I'm gonna show you a tool as well that we use for this. But this was our Parma site heart failure clinic visit efficiency. So we were finding that patients would come for a heart failure visit and they would spend about 80 minutes in the clinic, but only see their provider about 22 minutes of that time. So there was a lot of time that we needed to figure out what was happening during this time. How can we see what's value added and what's not value added, and how can we make this more efficient for our patients? What you see here, this map is called the current state value stream map. And what it is it follows the patient and it's a time trial. So it looks at, I checked in, I'm sitting in the waiting room. How many minutes am I sitting in the waiting room? Now I'm seeing my provider. How long is that? I'm sitting with the MA or the nurse, and we really go step by step and take a look at how much time there is. So we can see things like what's value added, seeing my provider, doing things with the nurse, with the MA. What's not value added, sitting in the waiting room, filling out a paper questionnaire I maybe could have filled out in advance beforehand, those types of things. And after the interventions with this group, there was the pre-intervention, it was the 80 minutes, and then post-intervention was 62 minutes. So they were able to eliminate nearly 20 minutes off of the visit just by making a few changes. And that was a 23% improvement, which is great. And if you could go to the next
The
slide.
key to that one, though,
Yeah.
is the fact that you didn't reduce the provider time with patient was sustained.
Yes.
So you didn't adversely impact provider time. Actually, you probably optimized provider time and you reduced inefficiency and non-provider time spent.
Exactly, yeah, amongst all the providers, the nurses as well, all the
Right.
doctors that they saw, everybody really got more efficient, and then we were able to get the patient having.
So how do you measure impact on outcome?
So that's-
a rhetorical question. So,
Yeah,
so I
okay.
mean, the other two, to me, you can clearly see the impact on outcome. For this one, there's a potential, and the good news is you didn't impact provider time, so I don't anticipate you'd see a reduction in a change in outcome. But I just think that's one thing to think. And this one, a follow-up would be monitoring to see if you've able to improve outcome or sustain the outcome with that.
But I think that you can use the patient experience,
Right.
and the patient's outcome as far as what their experience is as they wait through a
So I'm
clinic.
looking more for rehospitalization or
Yeah.
change in medication, trip to the emergency room to see that not only did you reduce it by 18 minutes, but you also reduced trips to the ED or reduced, potential hospitalization. So that's all rhetorical. So
Those are great for that continued improvement to think about what's our phase 2, how do we do this? I love it. That's
the good news is you go back and say they actually asked you some pointed questions. So.
Yeah, no, they did. Yeah, very good. And another tool we want to show you, which follows along with the heart failure clinic, this is our A3. And A3 is named an A3 because of the size of the paper that it is. So 11 inches by 17 inches, invented by engineers, but really it's a way to, I like to call it the storyboard for a project. So it's a way, if I did not work on this project, so I can look at this project and I can see what the problem was, what the current conditions were, how they got to their goals and their root causes, all the way through the conclusion and how they're sustaining it just by looking at this one document. It's a living document, so it's changed as we go through. You'll often see some of our A3s in motion where you'll maybe see 3 of these boxes done just because we haven't gotten to the other pieces yet. But at the end of a project, we want to have the full box. So we talked a little bit about the background of, how long the patients were waiting, those current conditions of that value stream map. After we do that, we work with our team and our sponsor to say, okay, what is our goal going to be? How are we going to work on the goals? And then what is the true root cause, and how can we make sure we're picking the root causes we're attacking that actually will help that goal? So a couple of tools we use down here. This is called the Pareto chart in the middle bottom here. And it looked at what are the tasks that a patient is doing while they're in the clinic. And then it takes a look at how often that's happening, and it gives you just a sense, it really helps you bucket your causes so that you can figure out what you want to tackle. So this was showing that the questionnaire, the paper questionnaire they were filling out, providers were looking at in clinic, not before, was the top overlapping task. And then this bottom thing here is called the fishbone. Our tool here is called the fishbone. So we use that a lot. That shows you the problem, and you look at 6 major causes, and then you look at why those causes are happening to truly get to a root cause. When we do a lot of RPI events, oftentimes we're filling out a fishbone with the staff that we're working with. And so in this team in particular, they created standard work to ensure everyone was working to their license. So the nurses were working to their license. There weren't overlapping tasks with MAs. They redesigned that questionnaire to be electronic and given beforehand, so it can both be done by patients beforehand and providers can see it beforehand, so it's not all happening in the visit. And then redesigning the RN workflow, because there were a lot of lapping tasks that an MA could be doing a lot of things, and then the RN could be better purposed in another area of the clinic to make the flow faster. For the implementation plan, those are called Gantt charts. So they show us those implementations that the team did, and then what each step is and when it happens. It's also another great at a glance thing if you see a Gantt chart for any project to know where a team is and what they're doing. And then we talked about the results from 80 minutes to 62 minutes, which was a 23% improvement. And then the conclusion is just how do we control it and sustain it? And it was through the creation of that standard work, through the redesigned questionnaire, making sure those are in place moving forward. So this is we use this for all of our projects. And then we also coach other teams on using this. So as we have other teams that we're coaching and mentoring through projects, we make sure that they also are filling out these A3s.
So all of our quality improvement committees are now using A3 methodology for problem solving and documenting their projects as part of their QAPI plan, which obviously when our regulators come in, they ask for.
We just want to show you a list sort of some of the things we've worked on past and present. So this just shows how, as we said earlier, throughout Metro Health. So outpatient, inpatient, perioperative, and then system level groups that work through across the whole system. This shows some of the people are in this room, and I think online of the people that we've worked with for some of these initiatives. And you know, we've done not just the 3 things or 4 things I've talked about. We really have done a lot of work with a small but mighty team, and we really try to support patient quality, safety, and experience in the work we do. So that's it for me if there's any questions.
I'm impressed. I mean, you've got it all there, the discipline though to carry through. I guess all your operators have exposure to the concepts of this structure, and they have like green belt, black belt. You do all that kind of rigor?
Our team does. Our team all is green belt certified, and then we train and coach on the tools as we go. So, and I think, you know, there are others in the organization that also have green belts and black belts. So, you know, they have the ability to do this, but we will really coach as we go. We're actually, one of the groups we have is our C-Quick and S-Quick group. So it's our Clinical Quality Improvement Committee and our Essential Services Quality Improvement Committee. And they work with across the organization. So for our S-Quick group, they are working in dietary and EVS, and each piece is picked a project. And then one of our team members, Katie, will go through and train them on going through the A3 and doing these things. And it really helps share the knowledge and help them become leaders and be able to use some of these tools as well.
So for most of your operators, are they seeing these tools for the first time when they're asked to be engaged?
Yeah, I would say, yeah, they are. Mm-hmm.
And the goal is to improve upon that, so
Sure.
there's more education to go, but yes. And we sort of take bite-sized pieces of it. They're certainly not getting a green belt education, but they're understanding. And we take it, you know, we do a 15-minute talk on just what is a fishbone diagram, and then you see it used. It's just very impressive to see the projects that our non-clinical and clinical groups are doing right now, using A3 methodology as the step forward to walk them through.
Yeah.
Good, thank you.
Thank you for your
So
time.
I got my time there, Kate, so.
Yeah.
So thank you for
Yeah.
the informative presentation, but the translation for me, I wrote down these notes, and so if you think about any one of those projects, you take it and you look at it. So, you know, improving patient outcomes, both from a quality perspective and reducing harm, you know, employee satisfaction. You think about the heart failure clinic, you know, your 80-minute visits, you're seeing maybe 3 patients in half a day, you're able to see 6
I
patients in
think
a
they
full
see
day.
7 a day, yeah.
They run over, they're staying late, the physicians, you know, got to do is pajama time on the Epic, and, you know, the staff are staying there late, they have things to do. From the patient experience perspective, you know, it's more efficient, there's less wasted time in that exam room while they're wondering what's going on. And then, you know, from a financial perspective, you know, that 18-minute reduction allows 1 more patient or maybe 2 more patients to be seen in heart failure, which faster time to diagnose, reduction in trips to the emergency room, reduction in trips for hospitalization, less stress for the family. So
Right.
just want to let you know the board appreciates the work you're doing. You can send that message out that it's, you know, the story is not just this story, but it's the second order impact of what you're doing. So I appreciate you coming here today.
Thank you. I'll pass Thank you.
Just a quick example too, turnover time, for example, we just implemented 2 weeks ago, but we've knocked 6 minutes off. My mathematical modeling will say if we knock 8 minutes, we can have 2 extra cases a day.
Yeah, but I don't even think it's about the 2 extra patients a day. It's even if you have the slack capacity to spend more time with a patient,
That's right.
so if you've got, the good news is if you give that the staff time and you've got a complex CHF patient that needs a little extra time, you're building in the extra time in the day where the provider's not gonna feel stressed to possibly rush through and miss something. So I'm just gonna say it's great work. So,
Yeah, we love it. So, thank you very much. Yeah.
all right. Well, thanks again for your presentation, Mary Kate. Next, we're gonna move into executive session to discuss hospital trade secrets as defined by the ORC 133.61. Consider appointment, employment, dismissal, discipline, promotion, demotion, or compensation of a public employee, or the investigation of charges or complaints against a public official in the conference with the public body's attorney. Discuss the disputes involving the public body that are subject of pending or imminent court action as defined by our IRS code 1221.22, section G. I need a motion to recess into executive session to discuss these matters. So moved. A second? Second. Okay, I have to do the roll call. Dr. Walker? Yes. I'll give Michael his time too. Yes.
Yes.
Ron? Yes. Okay. With that, I'm gonna ask the public to step out and we're gonna move into executive session. And I'm looking for the green light from Tanika. Okay, well, thank you for those updates. With no further business to bring before the committee, the meeting is now adjourned. Thank you. Alrighty.